I have to point this. Okay. So, my topic will be representing mostly a viewpoint of a European surgeon and what happens in Europe. So, if you have a historical perspective of surgery, we start at the beginning of the 20th century. And what was the situation there? It was the beginning of the triumph of open surgery. And during this, from the beginning to the year 1990 or 89, I put, they have built a big planet here of open surgery, because at the beginning of the last decade of this century, everything is possible by open technique, everything. And so surgeons were so dazzled by this kind of triumph that they will not see the appearance of new technology, and for instance, endoscopy. And they could not imagine that introducing endoscope in their daily practice could change totally the feature of surgery. And so M.I.S was still existing, but like a small satellite here, and ignored by the majority of the surgeons, even our academic leaders, they were considering that endoscopy was a sort of fashion of a day with no future, and devoted to physician or and probably for a surgeon of second category, you see. But some were not thinking inside this world, were not thinking the same, but they were not very numerous. They were scattered around the world, and they have no contact between them. And to have a certain power, they need to gather. And the first gathering of those surgeons convinced that endoscopy will be the future was the creation of the SAGES Society here in the States. And we have to be very grateful for the founding father of this society, because they were the first to create this society inside the open surgical world, and to try to establish a regular teaching program for M.I.S. But at that time, until 1989, regarding the education in M.I.S, the academic system delivered nothing at all. And some non-academic institutions, like society, like SAGES, began to train people, but it was only on endoscopic surgery. And this endoscopic surgery, flexible endoscopic surgery, was developed by physicians, by gastroenterologists, and they don't attract anymore the surgeon, because they don't find a keen interest to learn this type of surgery. And so this society remained of modest size. And in France, I had the same idea. And in 1987, I created, with some gastroenterologists, some radiologists, a very revolutionary concept of society called Society for Endoscopic Surgery and Interventional Radiology, mixing all the people having the ambition to make progress with the endoscope. But this society was also of very small dimension, because it was not attractive for the surgeon. And a very important event occurred in this year, 1989, And it was the birth of laparoscopic surgery. Why? Because just a few years ago, those surgeons having the intention to use endoscope received a very terrific weapon, the video camera. And with this video camera, they can show in real time what they were able to do. And the most well-trained in this field were the gynecologists. And seeing gynecologists removing ovarian cysts, treating ectopic pregnancy so nicely with laparoscopy, we had the idea to do the same for digestive surgery. And in Louisville, during this meeting, I presented this laparoscopic cholecystectomy done with very simple devices, electric cautery and so on. And in America, they start with a laser, but this technique was very simple. And it was really an earthquake, you see. SAGES at that time was celebrating his 20,000th member, I remember. So the audience was wide, around 600 people. And suddenly, 600 American surgeons became aware that it was not necessary to open a body to make an operation which is not a very basic operation like lipoly. And this earthquake generated a wave of enthusiasm, incredible, and like a tsunami. And immediately, those American surgeons, convinced of the interest of that, start to create an academic system of education. And this tsunami was rolling in a few years all around the world. And I put the date of 92 here because in 92, we had created in 90 the European Society of Endoscopic Surgery, and in 92, in association with SAGES, we organized the Third World Congress in Bordeaux, and we saw coming there more than 2,000 surgeons coming from every part of the world, and a very big contingent from Asia, because in Asia, in Japan, they have created the Japanese Society for the same aim. And also in Singapore, thanks to the dynamism of Peter Goh, they have created the Asian Society, ELSA. And I think, Michael, you are the secretary of this society now. Michael Lee, he is sleeping again. And so the success was so fantastic. We saw new operations like gastrectomy, colectomy, and so on, that at the end of this meeting with Gerald Marx, one of the founding fathers of the SAGES, we decided that to canalize this sort of enthusiasm, we need a sort of federation of all those societies to make harmonization of education and research on this topic. And it was the birth time of IFSES. And after this, you see, we are coming from 92 to today. You see, these small satellites penetrate inside the world of open surgery, and now the penetration is very important. And we have a complete academic educational program for this kind of surgery, but also non-academic, and it's very useful, and run by societies like SAGES, like all the members of IFSES. And if their program is very good, they could be endorsed by the academic institution in charge of this education. And in Europe, most of the countries are run on that way, that to be accredited, you have to pass examination inside of a university. It's not a college like in Anglo-Saxon world who deliver the accreditation. So, and this is the present. And what about the future? We will see this later on. And so, as a summary, last decade of the 20th century, it was really in the history of surgery a great turning point, because for the first time, people can see that it was no longer necessary to put their hands inside the body of their patient. It's very important. And after those two meetings, I think we open a new era of surgery, having as first concern, as first priority, the comfort of our patient. And so this is the picture of the founding day of IFSES, and you see that Elsa was represented, the Japanese also, SAGES, and Europe. And at this meeting, we met for the first time people from Latin America, and they decided also to join the federation, but they were not on the picture because it was in the cellar of a famous chateau, and when you put some Latin American guy in a cellar, you don't see them again, you see. And we could not have them on the picture. And what happens in Europe? In Europe, it was really an invasion, and this invasion started, the virus of M.I.S. Started to invade Europe from the city of Kiel in Germany, where Kurt Zem was running a center of laparoscopic surgery for gynecology. And in France, in Clermont-Ferrand, a very close friend of mine, Maurice-Antoine Bruat, was doing the same. And those guys gave the ideas for the French and the German to do the same for digestive surgery. And so it was at the end of the 80s, and in Lyon, Mouret met some fellows of Maurice-Antoine Bruat. I have direct contact with him, and François Dubois in Paris also can contact Mouret. And so at the end of 88, we were three to do laparoscopic cholecystectomy, having trained with the gynecologist. And in Germany, in Hans Troy in Cologne opened the same center. In Brussels, Guy Bernard Cadière, d'Allemagne and so on did the same. And in Dundee, Alfred Couchery do the same also. And I think at the end of the year 81, all those centers were delivering an official academic education for laparoscopic surgery. And next step were in Italy, in Spain, and so on. And it was really like an epidemic. And around 93, I think it's 93, Maresco opened his center, which is now a very, very big center. I think it's one of the best equipped center. And also a smallest one, but very efficient, in Trondheim, in the north of Norway, run by Ron Malvik. And after 94, it was really an explosion all around Europe. And in the western part of Europe, because the Berlin Wall fell down at the end of 1989, so surgeons of the eastern part of Europe have no information about this. And so in the western countries of Europe, now every city, even remote city, has a public hospital with a laparoscopic tower and somebody able to activate this properly. And as the organization of the surgical residency Cursus, I will show you the French model, which is the same there is some variation, but on the continental Europe, it's the same. In British Island, they have another system, but very close also. So people have to follow this Cursus. 3 years of a common trunk, and after this, 2 years more, and they are accredited as a general surgeon. And around the year 75, we create among the general surgery different specialties, and there are 8. And among the 8, we have the abdominal digestive tract surgery here, and it's 3 years more. So people go first to the common trunk, and after, if they make the choice of a specialization in digestive surgeries, they do there, and they have 3 years more to receive accreditation for digestive surgery. And at the beginning, we introduce modules of training and education and training in laparoscopic surgery at the stage here, after the 3 years of common trunks, and during the 2 years for general surgeon and 3 years for accreditation for digestive surgery. But the time coming, less and less people are following this way, and most of them are going this way. And we can divide this type of education in 2 parts. From 90 to 96, we have this kind of program, step by step. But the first step was to master this kind of operation, and after this we have this one. And at that time, the majority of our residents were stopping at this level here, and only in a specialized center they could receive this the addition of treatment. And we make a point, a sort of assessment when we turn the millennium here. And it was in Singapore during the 7th World Congress of Endoscopy. And we could make the assessment of what happened during those first years. And you see here the board of IFSES with all the representatives around the world. And we see here Alberto Schusleb, our president, actual president. And we were convinced that M.I.S was not the fashion of one night. M.I.S has passed over the non-written line. And so we decided that we implement in the brain of each surgeon the minimally invasive spirit. And regarding the education, we have to change our program to move to more anatomy teaching by medical imaging, extensive use of e-simulator, and also earlier introduction in clinical training for our residents. So our program, it's too late. Yeah, I'm sorry, because you gave me a topic so large. And so we change our program, and from the general surgery it's always the same channel. for the specialization, it's after 3 years of common trunk. We have 3 or 4 years now. We are moving for 4 years because of the restriction of the week, the hours of work for our resident. And we introduce the module for laparoscopic surgery during the common trunk. And after this, we complete the training by introducing the more sophisticated operation. And now, when our residents are leaving the university, they are at the level of colorectal surgery, and the other most advanced procedures are still reserved for very specialized units. And so we have also to change our institution, and where we are now, we are transforming open surgery in M.I.S surgery by Institute of Education, Research and Development in M.I.S, like the institution of Maresco, but now most of our teaching hospital has premises to have a dry lab, to have simulators and to train. And all those institutions have to have connection between them because the trainer of this hospital have to be trained in this institution. And what we are seeing, we are seeing that progressively all the benign disorders requiring surgery have passed this bridge between open surgery and M.I.S. And it is a continuing permanent education that can do that. And now oncology is on the good way also to pass to M.I.S, but organ transplant and trauma will remain in the domain of open surgery. And so changing our institution, so we think that we have to put together all those people involved in minimally invasive surgery, the surgeons, the radiologists, and the GI, and to create a center, and I think it's at the beginning, center specialized in minimally invasive interventional treatments. And we have created in 20 years a new shape of surgeon. A new shape of surgeon, we can define this surgeon who know very well the open surgery and the conventional laparoscopy. And this conventional laparoscopy is based on multiple port access and on the principle of triangulation here. And this is our aim, to train every surgeon now in this way. And I think it's the modern shape of a surgeon. And what about the future? The future, the very close future. Very close future, we will see the inflation of all those M.I.S formation and the center for minimally invasive therapy. And we have some boiling problem now because we have invested new space. We are now surgeon navigating in intracorporeal space, and we have different kind of space, and sometimes it's a sort of confusion. And you see, you have intracorporeal space, you have virtual space without natural orifice, we have cavity having natural orifices, and what they are their axis. And the percutaneous access is laparoscopic surgery, and it is now something completely accredited, and it is the new platform for surgery. And we have also another access possible, which is a very controversial and very burning discussion now. It's the access to the lumen of the cavity having natural orifice. And the second is natural orifice. You have access by the natural orifice. It is the flexible endoscopic surgery, which is very well established. But by percutaneous approach also, we can enter those cavities. And so what is NOTES now, in my opinion? Where is NOTES? Is NOTES among the M.I.S procedure? I don't know for the moment. I think we have to place NOTES like open surgery. NOTES have to prove that they are able to cross the bridge to become a M.I.S. And I think it's very, very important to have the society like SAGES have creating this group to study very, very precisely with a good scientific methodology. In Europe, you have the EuroNote, but for the moment, NOTES has to remain in this kind of institute for research and development, and the clinical application has to be done only in a clinical department who are backing up those kind of institution. The second question pending is single port access. Single port access, is it M.I.S? I think now single port access is well studied in those institutes, and I think that the question mark is falling down, because I think we are authorized now to use the single port access in a surgical unit for clinical application. So I will conclude. I'm sorry for this long time. And to predict long-term future, I had the chance to have some connection with a French doctor of the 16th century, and his name is Michel de Notre Dame, and he's more well known as Michael Nostradamus. And he told me what could be the long-term predictive, the long-term future. He said you have predictive factor where we are completely evident. Patient demands, they never change their demand. They want to be treated better with less adverse side effects. And we have the exponential development of technology, who provide you new devices, and who can make diagnosis of disease at a very early stage. And so those factors will make the future of the surgery. And at the end of this 21st century, I think, except for trauma and transplant, elective surgery first will have less and less indication, because during this time progress will be made in chemistry to make new drugs, in genetics and so on, and the remaining surgery will be mostly minimally invasive surgery. And surgeon will become navigator inside human body space, using very sophisticated device at remote control, no contact with his patient. We know the robot now, but Nostradamus say, I see some completely new device you cannot imagine of, and it's too early to deliver this prediction. And this surgeon will be based, those surgeons will be based in minimally invasive interventional treatments. And how it will function, during this century we see that surgical procedure and operator will be chosen by a group of experts. The procedure will standardize at extreme precision, and the choice of the operator will be the guarantee of nearly zero risk. And so this prediction, I think we see that what is the place of the traditional training of the surgeon, having a constant contact, physical contact with his mentor, and spending hours in the operating room. And I think this relationship is really unique. And is it dedicated to disappear? And so you see Lister here, and he has trained few people. You see Terrier here at the beginning of the 19th century operating with under the guideline of asepsy. We see modern surgical open surgery now, and with our possibility of tele-mentoring, tele-teaching, and so on, one mentor can teach thousands of fellows, but they never suppress the physical contact with the importance of a contact with your master. And I will show you here a picture. Philippe Mouret, who was the first to understand the importance of endoscope, was teaching a new surgeon in Italy. It was in February 2008, and just to the end of his life, it was three months before his death. He's never stopped to be a mentor, to be a teacher. And when we created all those society, Philippe never come if he was not able to have a live demonstration. It is the live demonstration for a surgeon is the core of the training. And I will finish by celebrating a famous founder. He has left the session now, but I think this man, Gerard Marx, was the first to initiate the creation of the SAGES, and he was the first to understand what important was the introduction of endoscopy in our profession. And in 20 years, he has changed with you all the feature of surgery. Excuse me for this.
Thank you very much.